it is not okay to wait until after the cath lab then to start your TTM, right? It needs to be started as soon as possible. And then those PCI candidates, having the cardiologist there, evaluating the patient and deciding, what's the path? Are we going direct to cath lab? Are we going to wait? Is it going to be delayed? So the recommendations on interventions had to do with airway, breathing, circulation, right? We want to titrate the FiO2 down as soon as we can get our blood gas and stabilization. We want the patient attached to monitors, assessing blood pressure, looking at our IV access and our fluid support and targeting our mean arterial pressure. The neurologic assessment. So with return of spontaneous circulation, if their GCS was greater than 8, so it's 9 to 15, you've got someone that's got less of a neurologic hit. So they're awake, they're following commands. You're not going to do targeted temperature management in that population, but what about those patients whose Glasgow coma scores are 3 to 8, and maybe they have reactive pupils and maybe they don't. So getting your neurologic assessment with your parameters for pupil accuracy. We happen to use a pupilometer, which quantifies pupil reactivity, and we use that as a trend monitor on an hourly basis throughout the first 3 to 5 days post-return of spontaneous circulation in our comatose patients. We also prioritize seizure monitoring early on. So our goal is to get some type of seizure monitoring device on the patient within 30 minutes after return of spontaneous circulation, again, in comatose patients. We want our physician experts, our providers, to be at the bedside as soon as possible. So getting the appropriate consults immediately so that we can have a team plan on where we're going. The physicians, the providers are going to be looking at that differential diagnosis, and they're going to lay out the plan of where we're going with our resuscitation, post-resuscitation care.